Now we'll talk about some of the drugs that are used for neurologic disease. We discussed glaucoma earlier in the lectures. It is the condition of increased intraocular pressure due to impairment of aqueous humor flow. Aqueous humor is produced by the ciliary body in the posterior chamber and travels to the anterior chamber through the pupil. It is resorbed through the canal of Schlemm. Sympathetic drive stimulates the beta receptors on the ciliary body to produce aqueous humor. It also stimulates the alpha-1 receptors so the pupils dilate, allowing more flow from the posterior to the anterior chamber. Parasympathetic drive stimulates the ciliary muscle and causes pupillary miosis. Once you understand the pathogenesis of glaucoma, it can be easier to remember which drugs are used to relieve the increased intraocular pressure. Alpha agonists decrease aqueous humor production, and brimonidine also increases the outflow of aqueous humor. The beta blockers decrease the production of aqueous humor and may also reduce secretion. There are no ophthalmic side effects, but timolol is the most likely drug to have systemic side effects. In patients with a normal nasolacrimal duct, the eye drops can drain to the nasal mucosa and be absorbed directly into the bloodstream, bypassing the hepatic metabolism that would usually affect timolol taken by mouth. Now, carbonic anhydrase inhibitors like acetazolamide reduce the amount of aqueous humor that is produced. Cholinomimetics such as pilocarpine, physostigmine, and ecothiopate cause miosis, and this decreases flow to the anterior chamber and contraction of the ciliary muscle, which ends up opening the trabecular meshwork, and it allows more aqueous humor to be resorbed. The prostaglandin analogs, such as latanoprost, increase outflow through the canal of Schlemm, and these drugs are now widely used as first-line therapy. Opioids are a class of drugs used to control pain, or analgesics. They are most commonly used for moderate to severe visceral pain, such as in the postoperative state. They act at opioid receptors. There are three types of opioid receptors: mu, delta, and kappa. Most opioids act at the mu receptor. All three opioid receptors are G-protein coupled receptors. When activated, these receptors decrease C-amp, they increase potassium conductance, and decrease calcium conductance. The net effect of the changes in potassium and calcium conductance is to decrease neuronal transmission of pain. Opioids can be fast-acting or slower-acting. The fast-acting opioids, like heroin, are associated with a higher rate of addiction. Methadone is used as a treatment for heroin addiction because it is slower-acting and therefore less addicting. It can act to bridge the patient from heroin towards the goal of no opioid use. Morphine is sometimes used for patients in acute pulmonary edema, where its anxiolytic effect reduces their sensation of dyspnea and allows for better synchronization with the ventilator. Dextromethorphan is an opioid used to suppress cough. It's an active ingredient in over-the-counter cough medications like Robitussin and NyQuil. And because constipation is a side effect of opioid use, they're also frequently used by patients to treat diarrhea. The most dangerous sequela of opioid overdose is respiratory depression, which can lead to death. And what is the treatment for opioid overdoses? Well, you need to give naloxone or naltrexone, which are both antagonists at the opioid receptor. Patients on opioids will also have pinpoint pupils, altered mental status. They can be stuporous or even comatose, and also nausea or vomiting. Commonly tested principles of opioids are tolerance, dependence, and withdrawal. Tolerance develops to most effects of opioids. Essentially, the more doses of drug you give, the less effect each dose has on the patient. So, in order to achieve the same amount of pain relief, you have to give more drug. The only effects of opioids that do not develop tolerance are constipation and miosis. In the hospital, anytime you prescribe opioids, you should also prescribe a bowel regimen to avoid constipation and its ill effects. Now, dependence is a state in which the body has adapted to the presence of the drug and requires it for normal function. Thus, opioids have the potential to be a drug of abuse, and you should be careful about prescribing these drugs for outpatients. However, and this is an important key concept, you should never withhold opioids from patients with a legitimate reason for pain simply out of fear of producing addiction. Last are the withdrawal symptoms of opioids, and those will be covered for you in the psychiatry pharmacology lectures. Butorphanol's trade name is Statil. It's important not so much for what it is used for, but rather to illustrate the concept of partial agonists. Butorphanol is a partial agonist at the mu receptor, but has a lower efficacy at the mu receptor than full agonists like morphine. So what happens? In the presence of a full opioid agonist, butorphanol competes for mu receptors with morphine, but it isn't as good at activating the G-protein coupled receptors. So there's less of an opioid effect. Taken to the extreme, this can cause withdrawal symptoms if the patient was previously taking a full opioid agonist and is given butorphanol. Now, it is equally as efficacious as morphine in relieving moderate pain, but it is less effective for alleviating severe pain. Butorphanol is a mixed-action opioid, meaning in addition to binding at the mu receptor, it also binds to kappa receptors. The good thing is that butorphanol and other partial agonist drugs have less likelihood of causing respiratory depression in patients. Tramadol is another opioid agonist, but it acts on other receptors as well. It inhibits serotonin and norepinephrine reuptake, meaning that it enhances the effect of those neurotransmitters. You can think of it as causing more serotonin and norepinephrine to exist at the synaptic cleft. Tramadol is used for chronic pain syndromes, and it has a similar side effect profile to opioids. One important thing to note for tramadol is that it does lower the seizure threshold. So in patients who may have a propensity for seizures, tramadol may push them over the edge.